Good morning, and thank you for being with us. This is Khalil Hachem, editor of Michigan.com, a digital business magazine serving the Arab American communities in Michigan. We provide business and real estate news, loan and lending information, support to small businesses, and much more. Visit us at Michigan.com. It's a beautiful fall day, and we hope that you are having a great start to your day. On behalf of US Arab Radio, we wish you the best of time and peace and happiness. We thank our sponsors, listeners, and supporters. In the news, Zelensky is visiting Congress, and then he's going to visit President Biden. I don't understand all of these visits and all of these time to give to Zelensky, the president of Ukraine. This is a war that we helped start, we instigated, and then we're funding billions and billions and billions of dollars every I want to say every week and every month, and we have given to Ukraine so then they can kill each other. And I understand that a lot of people feel that the Ukrainians need to defend themselves, but don't forget that we instigated that war. Okay, we knew that Putin was going to invade because he wasn't going to tolerate us pushing Ukraine to be part of NATO. He wasn't going to tolerate us, NATO, on his borders. And we have promised the Russians that we won't expand NATO to that area. However, we pushed them, and then we're funding this war. We are fighting in that war, although our government denies it. What's important to me here is two things: is all the people that have lost their lives. And I'm not saying it was appropriate and it was right for Russia to invade, but all the money that we're dumping into that war, we need it here. We need it the most. The other day I was reading about the Social Security Administration sending letters to a lot of people. I believe it's millions of people, asking them to give back an overpayment that they made. And the error was made by Social Security Administration. And this money was given to people and people spent it. These are unlimited income. Now people are scrambling to give that money back. Some of them are selling their homes. Some of them are taking on loans. They want to give that money back. It's not right. We have money to pay for a war. We have money to pay for other things, but we don't have money to bail our own citizens on limited income. Those are the people who most of them have worked very hard for this country. And now we're going to say to them, give us the money we gave you because we made a mistake. I understand that, public money and if there's a mistake needs to be corrected. But these people did not make a mistake. They did not. They didn't ask for this money. And now on their limited income, we're going to say, give us back this money. This needs to be corrected. I don't expect this government and these guys in Washington to correct this, because look what's going on in Washington right now. Republicans failed to agree among each others on funding the government because they're threatening with another shutdown. Every few months, we have to be threatened with another shutdown by the Republicans because the majority are the Democrats. And then the Democrats are in the White House. And this game between Republicans and Democrats about shutting down the government, Republicans try to use any excuses to cut spending. By spending we're talking about. Last time, what did they cut? They cut money that's due to seniors, that's due to, I believe, and that's due to poor people. We want to cut that. Okay. Now, they can't agree. Even Republicans can't agree among each other. Why do we have to shut down government every few months? We have to threaten and use that blackmail because we failed, or you failed, or rather they failed. These are the people we elected to do their business and serve us and protect us and do the right thing. We send them to Washington. We feed them. We give them money. We give them the best healthcare. When they talk about shutdown, I wish the first thing they do is cut off all healthcare, food, everything to Congress. Okay, let them pay out of their own pockets and let them be without healthcare, and then you'll see what happens. It's really unfortunate when we have a group of people in Washington acting like babies, whether they're Democrats or Republicans, and they cannot agree on keeping the government going. It's really unfair. It's really not the right thing to do. It's very unfortunate. I hope that they grow up and then that they will find a way to work together. And then, shutting down the government, what does that mean? That means that, a lot of things can't work. That means that it's a terrible time, and inflation, we're dealing with inflation, we're dealing with high interest rates, we're dealing with a lot of things. Okay. Shutting down the government, that means catastrophe to everything. And it's unfortunate. And why do we have to do that? What kind of setup is that? Every few months we have to shut down the government. Every few months we have to threaten each other and shut down the government, and give us 3 months here, 3 months there. It's nothing. They're not serving anybody. They're not saving money. Okay, they're voting to give money to war, billions of dollars, but we want to shut down the government. We want to do this. It's unfortunate. It's really, really unfortunate. In the another news, there was a meeting between Israeli Prime Minister Mr. Netanyahu and President Biden, and then Secretary of State Blinken is trying to sell us the fact that a peace between Saudi Arabia and Israel is a good thing, and it promotes the stability of the region and all of that. First, Saudi Arabia and Israel has never been at war, and they've been working together in secret for a long time. Second, what they're trying to do here is they're really trying to isolate the Palestinians more and more and more. Mr. Netanyahu has this idea that the more he isolates the Palestinians, okay, the weaker they get, and they're going to accept for a lot less what he's going to offer them. And basically, there's nothing more left for the Palestinians to really give up and accept. In 1948 and after 1948, it was maybe like 50-50, the land. Now, Palestinians don't even have 16%, and it's like a Swiss cheese. Just like a Swiss cheese, the land that they live on or control in the occupied territories and in Gaza. And I'm not going to talk about Gaza because that's even like an open prison right there. But here's what happened. You got peace with Dubai, and then United Arab Emirates, and the peace with Qatar, I believe. And then they said they built it as this is the best thing for the Middle East, and this is going to solve the big issue in the Middle East. It did not solve anything, because that's not the big issue in the Middle East. The big issue in the Middle East is the Arab-Israeli conflict, is the Palestinian-Israeli conflict. And if we don't target that and solve that, and then provide a just solution for the Palestinians, peace is not going to go in the Middle East, And it's really unfortunate, the atmosphere that we have in the Middle East and all the lies that they tell us that it is good for this and it is good for that. In general, it's good that they're talking about peace together, but they're not. This is no peace. There is no. If you don't solve the main issue in the Middle East, which is the Palestinian issue, there's going to be no peace. Okay, that is the most important, most fundamental issue in the Middle East to solve. And if you don't solve that, there is no issue. And I know that there are plenty of issues in the Middle East, Sunnis and Shias and killing each other, and in Libya. And look what happened in Libya. It's unfortunate. It's really, really unfortunate. We lost thousands of lives because of terrible bureaucracy, because of neglect, and that's going to happen in a lot of Middle Eastern countries. Okay. And the idea that Israelis have that the best thing for them is to live in an area where there is chaos all around them, that's not going to really help anybody. It's not going to help anybody. It's going to create more and more chaos, and we're going to have to pay for it. And this is something we don't want to do. We really don't. We wish everybody to live in peace, but if you don't solve the issue in the Middle East, which is the Palestinian-Israeli question and the Palestinian question, and give Palestinians a right to self-determination, and give them a land of their own to call home, there is no solution in the Middle East. It's very unfortunate, and And then, just to see it on the news like that, devoid of any meaning, it's very unfortunate. On this show, we try to cover as much as possible and as many as possible issues that are important to you. And today I want to talk about something that not many people want to talk about, and that's prostate cancer. And, as you all know, some of you may know that this month is a prostate cancer awareness month. And it's important to talk about it. And, listen to some of the numbers that I picked up today. About 288 or 289,000 people are diagnosed with prostate cancer every year. About 35, it says here 34,700 people die of prostate cancer. I'm sure some of these can be prevented if they are caught early. And with us this morning to discuss prostate cancer is Dr. Syed Mohammad Jafri, urologist at Corewell Health in Southeast Michigan. Thank you for being with us, Dr. Jafri, and I hope that I said your name correctly.
You said my name perfectly. Thank you so much, Khalil. I really appreciate being here.
Absolutely. Before we talk about the cancer, can you tell us what is the prostate? What's the function of it? And at what age we need to be aware of issues with the prostate?
So the prostate is an organ in the body. It sits next to the bladder, and the first part of the urine channel kind of goes through the prostate. And it basically, its main function is that when a man ejaculates, it provides a component in the semen to help the sperm when it gets into the female's genital tract. It'll also help to convert testosterone to a more kind of quote unquote potent form of testosterone, but mainly those are its purposes that it serves for a man.
Absolutely. And is it normal for changes in the prostate and what age?
Got it. So when I see a man for the prostate, I will see a man for the prostate for typically two different reasons. So I'll see them for something called BPH, or enlarged prostate, or benign prostatic hyperplasia, or I'll see them for prostate cancer. And those are two very different things. BPH, or enlarged prostate, lives on the inner part of the prostate. So it lives on the inner part or around the urethra, so around where you urinate from. And so that will often present with symptoms. So men will come in and they'll say, hey, it's taking me longer to go to the bathroom. I don't feel like I'm emptying my bladder. I'm going more often, or when I gotta go, I gotta run to the bathroom. I'm getting up at night. And so that is benign. Benign meaning not cancer. So most of the time when I see a man coming in and they're having urinary symptoms, I'm actually calming them down. I'm saying, hey, Mr. So-and-so, these are not signs of cancer. This is normal aging. It's like my beard getting white. You live long enough, your prostate gets bigger, you have trouble going to the bathroom.
At what age?
So at what age is, typically speaking, it's middle age. So we'll talk about mid 40s, 50s, 60s is when it'll start. And then it goes on, right? And so it can go on for, the rest of your life. So God willing, a long time. Prostate cancer is different. So prostate cancer lives on the outer part of the prostate. That's why the finger exam is done, right? To feel the outer edge. So we're kind of putting our finger in your rectum, trying to feel the outer edge of the prostate to feel a lump or a bump. And that often, because it's not near the inner part, it's not near the urethra, actually typically doesn't present with any symptoms. And so that's where seeing your doctor, seeing your primary care doctor, getting an evaluation for your regular physical, that's where they'll check your prostate to try to feel that, just because we can't use your urinary symptoms as a guide. And so that's where the age range for that is older, right? So that's where we're looking at men between the ages of 55 to 70 is when we'll say, okay, regardless of how you're feeling, there's a discussion that you can have with your physician, but we'll talk about getting a screening test, which would be either the finger exam as well as what we call the digital rectal exam, and then the blood test called the PSA.
Okay. So if we're doing the PSA every year, is that good enough frequency?
So that would be more than good enough. So
okay.
I will take a couple statements. So one is there's a huge caveat. I am a urologist, right? So I'm very biased. PSA screening, checking the PSA on a routine basis between the ages of 55 and 70. That is a discussion that you should have with your doctor your primary care or your urologist to say, is this something that I want to do or not? It's not at the same level that we talk about colonoscopy screening. It's not at the same level that we talk about mammograms. But I personally find there's a benefit, to that if you have a good doctor that's interpreting those results with you that can help patients significantly. So that, depending on the levels, having that checked once a year, more than enough. Sometimes we can even decrease the interval. So sometimes we'll say once every 2-3 years, but definitely once a year between the ages of 50 and 70. For most men, especially most of our Arab men, that's plenty, more than enough, very helpful.
What are we looking for in the reading?
So it depends. So my very political answer, right? So when I'm feeling the prostate, I'm trying to feel a lump or a bump. We call that a nodule. Okay, so if I feel a nodule, it doesn't matter what the PSA number is, that warrants an evaluation. When we're talking about the blood test, it depends. And so it depends on their age, it depends on their family history. And so, sometimes we'll say higher than 2.5 is abnormal. Sometimes we'll say higher than 4 is abnormal. And so it varies on the size of the prostate, what their old PSA numbers are, how old they are. So there's a lot of different variables that come into play for me to tell somebody, hey, your number is normal, or hey, your number is abnormal.
Is there any way around a lot of men bulk at the finger test?
Yes. So I would say if you bulk at the finger test, that shouldn't tell you not to get seen. Yeah. I think I would say just getting the blood test is, in my opinion, probably plenty enough. The finger test does, for me, provide some extra information, but to be honest, I think there's stronger data or stronger support to just do the blood test. And so if the reason that you're not getting seen is because you don't want the finger test, fine. Just tell your doctor, say, look, I don't want to do the finger test, but I'll do the blood test. And from a screening you from the prostate standpoint, that will be plenty.
And there is a test, and then you're not really happy with the results. What's the second step?
So the first thing I do is I always double check. So anytime, so in my practice, the vast majority of the time, a patient has seen their primary care physician. They had a physical. The physical showed the blood test. They say, hey, go see Jafri. Go see Dr. Jafri. And so when I see them, and if I examine them and their exam is normal, I always double check it. And I would say probably 20 to 30% time when I check it again, it's normal, right? So when you go for your physical, you're getting multiple tests, right? So multiple tests. And so sometimes there can be a lab error. Sometimes you could have had some inflammation. And so that will cause that number to be elevated. But when you check it again, it's normal. So I always, I check it one more time. If that number is abnormal, confirmed to be abnormal, then the next step that I would say for almost all of my patients is I'll order actually what's called an MRI, so an X-ray test. So an MRI is an X-ray test where they'll give you X-ray dye in your IV and they'll take pictures of your prostate. And so when we're taking pictures of your prostate, I'm looking for 2 features or 2 factors to say, does this person need further evaluation or not? So one of those features is a calculation I make. We call that the PSA density. So that will take your PSA and in relation to how big the prostate is. So what does PSA stand for? It stands for prostate-specific antigen. What does it not stand for? It doesn't stand for prostate cancer-specific antigen. So it's not perfect for that. So sometimes I can blame your number for just the prostate being larger, right? So again, enlarged prostate, prostate cancer, 2 different things. Separately, what the radiology department has gotten really good at, what radiologists have been gotten really good at is separately seeing, is there a spot, regardless of what that calculation is, that's concerning or not. So what they'll see is they'll see a lesion or a spot on the MRI, and they'll score that 1 through 5. And so if you have what's called the PI-RAD scoring, if it's a 4 or a 5, then I would say, okay, this person needs a biopsy to evaluate because of that spot. So if either of those are abnormal, then that requires a test called a biopsy.
What we're going to do, Dr. Jafri, we're going to take a short break. We'll be right back. Please stay tuned.
Were you recently at the emergency room? urgent care, or at your doctor's office, being told you need a hand, wrist, or elbow specialist? At the Katranji Hand Center, we offer the latest techniques in hand, wrist, and elbow care. From sports injuries to work injuries to everyday hand, wrist, and elbow problems, the specialists at Katranji Hand Center are here to get you back on track. Call us in Troy today at 248-869-4263 or visit us at katranjihandcenter.com to schedule your appointment today.
Life for Relief and Development has now been rated as one of the best charities for humanitarian aid. Life's humanitarian projects span the globe, and Life is celebrating its 30th anniversary of providing essential life-saving aid to people and communities in 36 countries, regardless of race, color, religion, or cultural background. Where there is life, there is hope. And when disaster occurs here or around the world, including being one of the first responders to the Turkey-Syria earthquake crisis, Life for Relief and Development rushes in to provide food, medical aid, and shelter to those in need. We are looking to help the earthquake victims, and we take 0% overhead on emergency donations. So please help improve these efforts. Learn more about our involvement to help the helpless and bring hope where it's needed most, and make your tax-deductible donation to Life for Relief and Development now at lifeusa.org or call 248-424-7493. That's 248-424-7493. Get ready for an amazing experience at Ishtar Restaurant on 15 Mile Road in Sterling Heights. Enjoy excellent hospitality from owners Ali Al-Baghdadi and Fatty Bonham, serving the best in Mediterranean food. Try Chef Ali Al-Baghdadi's famous shawarma, the best Iraqi grills and food, and the best Arabic and international dishes. Dine in our authentic atmosphere or take out. Call 586-698-2585 or check us out on Facebook. Ishtar Restaurant practices all CDC guidelines and is open every day 11 a.m. to 10 p.m. Have an amazing experience today at Ishtar Restaurant, 3625 15 Mile Road, Sterling Heights.
Welcome back, and thank you for being with us. We're talking to Dr. Jafri about prostate cancer. Before we went on break, we're talking about biopsy. How is that done?
So a biopsy is done in one of two ways. So the more, I would say, common way that you'll get it done is what we call a transrectal ultrasound guided biopsy. So what happens is you get an ultrasound, and then through the ultrasound, we'll take samples that kind of go through the rectum, and they take little samples of the prostate. The other way the ultrasound is done is you have biopsies we call transperineal. So they'll put an ultrasound in the bottom, and then if you think of the skin between your anus and your scrotum, the needles are that way, so not going through the rectum. And you can have urologists will debate on which one is better or not, but those are the two most common ways they do. It is an uncomfortable test, right? So that the test is uncomfortable. It's short. In my hands, it takes about 5 minutes. I would say some urologists will take them about 10 minutes. So it is not the long test, but it is uncomfortable, right? And so that's why, like I talked to you before the break, we talked about all the different things that we'll do beforehand to really confirm, does the patient need a biopsy or not? Because that test can be uncomfortable. My office, in some offices will even offer, let's say that's a source of anxiety. You say, oh my God, I really don't want this. Sometimes there's things that we can provide. So like in our office, we have a machine where you can get breathing gas, like nitrous gas. Think of it like when you're at the dentist, they have that gas that pumps you down. That's something that we offer patients to try to help, just to allay that. But surprisingly, for most patients, they won't even need that. And so we do put numbing medicine there next to the prostate, so that again, another way to try to help out from a comfort standpoint.
Yeah. Are there any what are the time frame? I find out there is something abnormal. I guess that depends on what kind of cancer it is. Is that correct? There may be different cancers.
Are you saying about how soon to get a biopsy, or you're saying after the biopsy?
After the biopsy.
So let's say that we diagnose you with prostate cancer. Mm-hmm. Okay. Prostate cancer, we have time. So prostate cancer is one of those things that we have our time. We plan when we want to start the treatment. There's almost never is there an emergency that we would say that we have to rush to treatment. And so you get time to kind of plan and decide what treatment you want, and time to plan when to start the treatment. So prostate cancer, almost invariably, you have time before you need to start treatment.
Okay. So it's not like other cancers, there's something that moves really fast and others that slow, and once you discover it, you really have not much time to really react to it.
Absolutely, you have a lot of time.
Yeah. Now, as far as treatment, and I hear people who've had part of it removed, or what other treatments are there, and when do you decide we have to remove that part?
So when I see somebody back for my pathology report, for the vast majority of patients, this is the discussion that I'll have. So the first statement that I'll tell them is, are you dying from prostate cancer? And the answer almost always is no. The second question that I'll tell them is, do you have prostate cancer that has spread? And so there's certain features that we'll use to then decide, does that person need testing to check for spread or not? Meaning their pathology score or their PSA number or how the prostate felt. But even for that, the vast majority of my patients, I'll say no, and they don't need any further testing to check for that. The next part that I'll tell them is do you have prostate cancer that I need to treat? And that's where the difficulty comes, meaning deciding what to do. So in my practice, about half to 2/3 of my men that I diagnose with prostate cancer, I actually just monitor them, survey them, active surveillance, meaning that we're going to keep an eye on it, make sure that it doesn't get worse, and go from there. For the other subset of patients, then I'll say, hey, you have prostate cancer that treatment would be of benefit. And then we have to choose surgery versus radiation. Do I remove your prostate, a robotic surgery, or do we radiate and give a radiation treatment that a radiation oncologist would give? And that's where we had that discussion as to how both of those treatments are given. Do we feel like one is a better choice or not for them? What's the pros and cons of those choices? And that's where the real challenge comes. In certain scenarios, like if you came in and you had a kidney mass, it's very simple. I say, hey, you have this tumor in your kidney, I'm going to remove it. We don't really have to think about it. But prostate cancer is a very, very kind of nuanced discussion that I'll have with the patient, with their spouse, with their families, to then let them decide between the choices. That's where the real difficulty comes in.
Yeah. So it depends from case to case how much the removal is there and what part of the prostate needs to be removed. Is that correct?
So that is a very controversial question. So I would say, by and large, when we're talking about surgery, we're talking about removing the whole prostate coming out.
Okay.
There are certain people who are studying in select patients talking about treating a portion of the prostate. So not removing a portion, but either freezing or burning or ultrasound-guided treatments on a portion of the prostate. We call that a focal treatment. Mm-hmm. But I would say the vast majority of patients that are having surgery, they're having the whole prostate removed, a prostatectomy. And I would say in the majority of centers, like big volume centers like that I have at Beaumont Hospital, where we're doing robotic surgery to remove the whole prostate.
If part or full or treatment, what is the side effect on the functions of the prostate, or the creating on their sexual activities? What is the effect on that?
Yeah, so that's the big part with cancer treatment for the prostate. So when we remove the prostate, that surgery typically takes about 3 to 4 hours, sometimes a little bit less. Some of my patients, we're doing now a one incision or a single port prostatectomy, so I'm able to send people home the same day a lot of times now too. But they'll go home and they'll have a catheter. So they'll have a catheter and a bag that collects the urine, and that stays in for a week, because what happens after we remove the prostate is we connect the bladder to the urine channel. So we put stitches to connect those two together. And then a week after surgery, typically we can remove the catheter. When we remove the catheter, people are still healing, right? So they will have leakage, wearing pads or diapers. How long that lasts, how significant that lasts is variable. For some people, some of their urinary symptoms get better. So the people who had difficulty urinating, slow stream, hesitancy, a lot of times those, because they were prostate related, actually get better. But the leaking can be frustrating, for people in the beginning. So that's why I'll have people do exercises, stretches. Sometimes I'll even send them physical therapy, kind of build up the strength around their pelvic floor. Really, really, really bad. My life stinks because I'm leaking urine less than 5% of the time. So that's uncommon. but a little bit of leaking, that if you cough, sneeze, lift something heavy, that you'll wear like a liner in your underwear, that's about 15 to 20% of the time. Sexual activity is a different story. So there are nerves or nerve and blood vessel tissue that are around the prostate. And for some men, if their prostate cancer is not aggressive, we can try to spare those nerves. For some men, our primary focus is to cure them from cancer. So some men, we're less aggressive in our ability to save those nerves. And erectile dysfunction, sexual dysfunction is a real downside that can happen after having your prostate removed. And so that can happen, upwards of 50, 70% of men can have difficulty with that. Now, can that be treated? It can be treated. It's just a question of how aggressively men will want that treated, whether it's medications, whether it's injections, whether it's surgery. There are ways to restore sexual function. But that is, one of the big downsides that can happen as you're trying to cure people from prostate cancer.
It depends on the age as well, also.
Depends on the age, depends on, function. It's like a very natural thing. It's like my beard getting white, as you can see, as you live longer, your erection function goes down, right, in a natural way. But how people's erectile function is before surgery, what age they have, will play a factor into how they recover from having surgery. Yes, absolutely.
Absolutely. So the tube that brings urine to the bladder really runs inside the prostate.
Correct.
And this is why if there is any enlargement, even though it's not cancerous, it would affect us, not able to urinate or frequency or whatever it is, that these are the symptoms that we have.
Yeah, exactly.
Yeah. Is it true that all men experience, or most men experience, enlargement of the prostate?
To a certain degree, yes. The analogy that I give is like looking at hair, right? So some people, they lose hair quickly. Some people, they're 90 years old and they have a full head of hair, right? Yeah. And so how much your prostate grows or how tight your prostate is variable. And it has nothing to do with what your lifestyle is, right? It doesn't matter how much you exercise or what you eat or whatever. It's going to do what it's going to do. It's just like, my hair. It doesn't matter how much I want to do. I still have, very little hair.
Sure. Is it genetic?
I would say so, yes. Mostly.
Yeah.
So you can blame your parents.
Okay. So as far as a prevention, other than the test, what can we do?
Really, I would say nothing. There is a medication that we give for enlarged prostate that's been studied to try to decrease the risk of prostate cancer. And the data on that is kind of mixed as the pros and cons of taking that. And so I don't have a single patient that I have recommended, quote unquote, chemo prevention from prostate cancer. Anecdotally, I think the healthier you are, the better you live. That can help out. But is there anything that I can say, okay, avoid this or do that? No. It's not like lung cancer with smoking that we say don't smoke. It's nothing like that. It's one of those things that's a natural occurrence that can happen for men as they get older. But I don't have like a lifestyle recommendation as a prevention. No.
So the what they say about the frequency of sexual activities that could help prevent cancer and all of that, and this is really basically
the studies on that are mixed.
You mentioned the medication that you may give to an enlarged prostate that is not cancerous. Do these medications not cause cancer, but do they have a risk of causing cancer?
So for enlarged prostate, there's kind of different categories of medication that we'll give for men who have urinary symptoms. And so one of the medications can, the best way to describe it is it can shrink the prostate. And so that's been studied to see if it can reduce the chance of developing prostate cancer. And so when you look at the data is a little bit difficult to interpret in the sense that, yes, you can take that medicine, it can reduce the diagnosis of prostate cancer, but then there's a subset of patients that are diagnosed with prostate cancer that it's more aggressive. And so it's hard to kind of view that, right? And so you'll have urologists that will kind of question, is that truly a concern or not about that higher risk disease or not? But because of that, and because the benefit wasn't so great, and because now, even those men we wouldn't even treat that had the lower risk disease anyways, you don't see a groundswell of support to say that we should take this medication from a cancer prevention standpoint.
Sure. And I want to continue focusing on cancer and the prostate. I understand the in enlarged prostate, that's a totally different discussion and has totally different solutions, and we can do that another time. But we want to encourage our men to, and I like to remind our listeners that prostate issues are for men only. Is that am I correct?
100%.
Yes. So what do you want to encourage our men who are listening?
So I would encourage in a couple different ways. So one way I would encourage is the evaluation is very simple, right? It's a simple discussion with your doctor and having a blood test. The next part is I would say in the Arab community, the word cancer is a very, very, very scary word. Prostate cancer is very treatable. And diagnosing it earlier, especially when we're talking about some of these negative possible lifestyle changes from treatment, are easier to manage, less possible when we're dealing with it when it's less aggressive. And I would say for the vast majority of my men, they do awesome. A lot of my discussions for them, when I diagnose them, I'll say, Mr. Jones, I'll say, Mr. Khalil, right? Mr. Jafri, I'll say, you're going to do great. Yeah. And it's a question of now deciding what are we going to do for your treatment, but you're going to do great. And I tell them that. I look at them dead in the eyes and I say, you're going to do great. And so it's one of those things that if we catch it early, then the treatment's so much easier and the difficulty that you'll have is so much less. And so, and whether you get it checked or not, then you're not going to know. And so, and getting checked is so simple, especially now we're getting so much better at how we check and we're getting better at what treatments we provide. And a lot of people we don't even need to treat. We just keep an eye on it. And so that's what I would try to give as my number one reassurance is to say, it's not as bad as you think. The testing is not as bad as you think and the treatment is not as bad as you think, but, find a good urologist, that you trust and talk to them and ask them and say, hey, what's going on? Why, what do you recommend from me?
Absolutely. Final thoughts.
I think I'm just so appreciative to have this opportunity to talk here. I think my hope is that this is a window, even just in general, for guys to get evaluated medically, right? So, I know many of us are bad at seeing the doctor anyways. And so hopefully people listen to this and they'll get their first physical, right? And improve their health. And, prostate cancer is so common. We all know somebody who has it. And just being aware and getting this awareness out there is such a blessing for me to have this opportunity to talk with you.
Thank you so much. I really appreciate it. We're going to take a short break. We'll be right back. Please stay tuned.
Are you going to start a restaurant or grocery store soon? Do you need floor plans and designs? Call Naji Abood at 734-744-9796. Do you want to buy kitchen and restaurant equipment at discount prices? Call Naji Abood now, 734-744-9796. New Concept Products and Design, the trademark of kitchen equipment. 5% discount on all purchases of $75,000 or more. New Concept Products and Design, new location, 31185 Schoolcraft in Livonia. Learn more at www.newconceptproducts.com. Call Naji Abood, 734-744-9796.
At Top Rehab Physical Therapy Clinic in Dearborn, we provide effective physical therapy sessions in order to limit pain and discomfort. Top Rehab provides physical therapy care for any diagnosis prescribed by a physician, and we regularly see and treat conditions such as stroke, TMJ, fibromyalgia, sciatica, joint pain, and more. We use a variety of pain management methods, including modalities, soft tissue mobilization, and therapeutic exercise. If you're in need of physical rehabilitation or physical therapy, get the highest quality health care at Top Rehab. Most insurance is accepted and we're open Monday, Wednesday, and Friday 8 to 6, Tuesday and Thursday 8 to 5, and Saturday 10 till 2. Call for an appointment today at 313-846-0555. That's 313-846-0555. Choose Top Rehab Physical Therapy Clinic on Michigan Avenue in Dearborn. Life's too short to be in pain.
Welcome back, and thank you for being with us. This is Khalil Hachem. I want to thank Dr. Jafri for being with us earlier, talking about prostate cancer awareness. This is Prostate Cancer Awareness Month, and we encourage all men to talk to their doctors, get checked. This is the best way for prevention for prostate cancer. And we're going to continue more or less talking about a medical issue, but this is more on the insurance side or on the service side. And with us this morning is Meghan Groen. She's Senior Deputy Director, Behavioral and Physical Health and Aging Services Administration with the state of Michigan. She oversees Michigan's Medicaid program services for those with developmental disabilities and long-term care and aging programs. Good morning, and thank you for being with us.
Good morning. Thank you so much for having me.
Absolutely. So that's a long title. I hope they pay you for the length of the title.
Well, there's a lot of things that we're doing in that, and a lot of good work and a good team in there. So
absolutely.
Yeah.
We appreciate all you do. This is a great service to the community, and we wanted to make sure that our listeners and our community understands really what's going on. Before we talk about the updates, what is Medicaid?
What is Medicaid? So Medicaid is comprehensive health insurance, high quality services for low income people in the state of Michigan. Okay. So every state has a Medicaid program, but we specifically have one for Michigan. It's a partnership with the federal government.
Okay. Who qualifies for it?
Yeah. So if you are 138% of the federal poverty level and below, you're going to qualify for the Healthy Michigan Plan in Michigan. And that is, again, comprehensive, high quality health insurance. We do have different programs. So you may have a different eligibility for children or things like that, depending on your household. So if people want to go to My Bridges, at michigan.gov, they can definitely see if they qualify for all sorts of different programs based on their income.
Absolutely. So if they go to the exchange, fill out an application, and they tell them, well, you qualify for Medicaid, then they can go to the state. Is that correct?
Absolutely. So the exchange is where you're going to purchase health insurance that is subsidized. So if you're just above that threshold and you don't qualify for Medicaid, then you can get Medicaid you can get comprehensive health care on the exchange. If you do, in fact, qualify for Medicaid, they're going to send you back over so that you get into that state-sponsored coverage.
Okay. Is there like I understand you have different programs. Some people don't pay any money. Some people pay some money or more than others, depending on their income?
Yeah, so that is right on the health insurance exchange. So for folks who are maybe just above that income threshold for Medicaid, they're going to be able to buy coverage on the exchange for sometimes as low as $10 a month, but that's also based on your income. And so anyone can actually purchase on that space over on the exchange. But if your income is a little bit lower, you're going to qualify for Medicaid. And then we have no premiums in that Medicaid program for adults.
Oh, okay. Just adults and children and all of that.
Yeah. So we will get you in the Michigan Medicaid program. So either way you access the system, we'll make sure that you're in the coverage that really meets the needs of your family. And that, it's going to be the best situation for your family.
So a family of 4, what's the threshold?
Oh my goodness. It is that eligibility is based on your household size and a number of different factors. So if you go on to My Bridges at michigan.gov, you're going to be able to put in that information. We have eligibility specialists. You can also call, and there's a lot of different opportunities for folks to really get that individual attention, because we're going to want to make sure that you qualify or that you get into the program that you qualify for that meets your needs the best.
Absolutely. And I from last time I looked at it, if people call and they need help with different languages, that's available as well.
Absolutely. We definitely make sure that we have the translation services, that we've got folks that can help you. And so that is a piece that we definitely make sure that we have available. And it can get a little bit tricky, right? With some of these government programs, we're a little wonky. We want to make sure, even if you think you might be over income for an adult, your children might qualify for My Child. So we really do want to make sure people are reaching out to us so that we can figure out and help them with that eligibility, and make sure, even if we can't cover them, that we can cover their children. So that's one piece that I think people don't know. There's not just like one set number, right? If you're over this or under this. And so we really do want to make sure that people are getting that enrollment specialist help. And again, then if we can't help them in the Medicaid program, they'll move over to the exchange and potentially be able to get coverage for, as low as $10 a month, which is a pretty good deal for your whole family.
Absolutely, absolutely. Even if someone does not qualify for any other programs, like food stamps or other things like that, they may qualify for healthcare. Is that correct?
That's correct. Yeah. A lot of these programs have different eligibility. Actually, if you go on to MyBridges, so it's michigan.gov/MyBridges, you'll be able to look at your eligibility, not just for Medicaid, but other programs through the state of Michigan, where that be food assistance, heating assistance, all of those different pieces. And the same specialist, if you're calling and kind of working through that, can help you with a variety of programs, child tax credit, all sorts of different things.
Then it seems like there's a lot of good programs. Some people really don't know about them, so they really need to talk to someone and try to get the help. Our main concern is that a lot of people have dropped and this really has nothing to do with the updates on Medicaid, but I just want to bring this in to alert people that a lot of children are not caught up on vaccination. And they really need to, and they complain, I don't have insurance, I don't have this, and this is really a good way to make sure that, and I think the state monitors who is vaccinated, who is not. Is that correct?
Yeah, the Michigan Department of Health and Human Services does have that information. We work with providers and schools and all sorts of folks to, make sure that we have those vaccination pieces and records in place. But yeah, we are definitely encouraging, I understand some people missed some vaccinations over the pandemic, those pieces, but there's no cost to that vaccination. So whether it's with your provider or a local health clinic or something like that, we can definitely work with you and make sure that you've got access to get your children vaccinated.
Absolutely. Absolutely. Because we want to really encourage as many people to get the preventive care they need, so they don't find themselves in bigger problems and facing bigger, issues with healthcare. Hopefully that we encourage enough people to visit the website, call the state, and get enrolled. Now that we know what Medicaid is, what are the changes?
So the changes are that during the public health emergency at the federal level, we kept people on Medicaid. So there was continuous enrollment. Previous to that, people needed to re-enroll every year, right? So it's called a determination. You kind of just do your paperwork every year. Just make sure that we know what your needs are, whether your income has changed, whether your household size has changed, to that type of thing. And you do fill that out on an annual basis. During the public health emergency, that paused and we just kept everybody on. And that was, that was something that we worked with the federal government on. During the legislation happened in December of last year, and we started doing redeterminations in June of 2023. And that was a requirement of the federal government, kind of as that public health emergency wound down, that people will need to do that redetermination process. Which, we've been doing this for a long time in the Michigan Medicaid program, so that's okay. But some of our beneficiaries haven't done this in 3 years, and either are newer to the program and they've never gone through it before, or they just haven't done it in 3 years. So we want to make sure that people are prepared for that, and that they know that that's going to be coming in the mail.
If it is income driven, and you guys know, it's very easy for you to verify and know what everybody's income is. Why do we have to, fill out more paperwork?
Yeah, no, that's a great question. So we do have the ability that we work on again with the federal government to we call it passively renew. So that means if we have income information for you, because we just talked about all those other benefit programs, right? So let's say you're already working with us on one of the benefit programs you're in and you've verified your income, you've done that type of thing. We can work with those programs to make sure that then we can use that in Michigan Medicaid so that we can just go ahead on the back end and redetermine you as eligible because we already know that information. Not everybody has, that income on file and those pieces that are current. So to the extent we have that information, and we've been working really closely, the federal government gave us some flexibilities to work to be able to use some different data sources that we have, whether or not you also used maybe our unemployment insurance, that type of thing, so that we can have those programs work together to make sure that we're passively renewing so that people don't have to fill that paperwork out. Unfortunately, not everyone is going to have that information current enough for us to be able to do that. But people should be assured that, we are working as hard as we can to reduce that paperwork burden. And if you're doing it in one place, that the state of Michigan is kind of working together to make sure that, we can help people do that more efficiently for all the programs that they're using.
Okay. And if people need help, where are they going to go?
If people need help, they can go to an MDHHS local office. We have them in all of our communities. You can go to michigan.gov/mybridges. And we also do have services over the phone as well. If people want to go to michigan.gov, stay covered, or call the health insurance hotline too, that's 877-999-6442. And that is for, again, comprehensive insurance. So whether it's in Michigan Medicaid or if it's on the health insurance exchange.
Could you repeat that phone number, please?
Yep. So the health insurance for the Department of Insurance and Financial Services is 877-999-6442. And they are open Monday through Friday from 8 a.m. to 5 p.m.
Is there anything I haven't asked you that people need to know about this program?
The one thing, we talked about it briefly, but I do just want to say one more time, if you think you might be over income, if you're not sure if you're eligible, fill out that paperwork when it comes in, fill out that packet, because we might be able to cover your children. There might be something else that you're eligible for that we have a higher threshold on. And we really just want to make sure people are staying covered and getting, what they need to make sure that they keep their family safe and healthy.
We have a question somebody sent to me the other day. I was talking to them that I'm going to be discussing this, and they said if they received, if they have Medicaid as a backup because they already have a different one, do they still have to fill out the paperwork?
Yeah, you're still going to want to fill out that paperwork if you want to continue to use Medicaid as that secondary insurance. It is income-based. So if you qualify, you qualify. That primary insurance you have, if you have it through maybe an employer or something like that, is what'll happen first. But if you're using Medicaid as a secondary insurance, and you're going to want to fill out that paperwork so that you keep that. Some people, that might not be something they need anymore, and that's okay too. We just want to make sure that everyone has the coverage they need to keep their family healthy.
Absolutely. And the paperwork mainly, trying to assess income versus eligibility.
Yep, it's going to do that income piece, and that's going to assess your eligibility. So it is a pre-populated form. So we all the information we have, we're sending it to you. You kind of verify those pieces. And you send it back to us. If we haven't heard from you, we're going to be sending you a text message, giving you a phone call, that type of thing. Because again, we want to make sure that people are maintaining that coverage.
Absolutely. Ms. Groen, thank you so much for taking the time to be with us. I really appreciate your time and information. This is really valuable information. We hope that our community takes advantage of these programs that you offer.
Absolutely. Thank you so much. I really appreciate it.
Absolutely. We're going to take a short break. We'll be right back. Please stay tuned.
Ziyad brand. quality products from our family to yours. Ziyad Brothers Importing offers the finest quality products, including brands like Sultan, Kraft, Nestle, Hook, Rico Picon, Dana, and many more. Ask your retailer to carry these fine products because you deserve the very best. For more information, visit our website at www.ziyad.com. That's www.ziyad.com. Ziyad, quality products from our family to yours.
When you're looking for the best in optical care, Dr. Imad Nakash is your doctor to see. With years of experience and thousands of successful procedures performed, you can trust your eyes to Dr. Imad Nakash. See Dr. Imad Nakash and his professional staff for your eye care needs. There's 2 locations to serve you. In Hazel Park, call 248-336-3937. 248-336-3937. In Rochester Hills, call 248-299-3937. That's 248-299-3937.
Welcome back, and thank you for being with us. And I want to thank Meghan Groen for being with us. She was Senior Deputy Director of Behavioral and Physical Health and Aging Services Administration with the state of Michigan. She talked to us about Medicaid and how you can update your information with Medicaid. And now, before we close the program, I want to talk to you a little bit about what happened recently, or yesterday rather, with the federal government when they kept the the interest rates unchanged. And that's really good news. The federal government has been trying to tackle inflation, and to tackle inflation has been a daunting task because people keep spending. And, tackling inflation, to do that, the federal government normally raises the interest rate. And raising the interest rate means they're making everything you borrow more expensive. Loans on cars, credit cards, loans on houses, so forth and so on is going to be more expensive. At this time, I think the interest rate is hovering around 7%. Not long ago, it was about 2%, and not long ago, it was 0%. And that's an anomaly. I was looking at some information historically, and interest rates have gotten as high as 18% in the 80s and has gone down all the way to almost 0% in 2010, all the way to 2016, then went up above 2%, then went down to 0%, and now it is hovering around 6-7%, which is fairly normal. A normal rate is about 6%, and but the Feds want to make sure that inflation is being tackled and being taken care of. How does it affect? I just want to, one aspect of this, I want to make sure that actually 2 things. Number one, if you have a credit cards, and I'm sure those interest rates are very, very high, I encourage you to look for their companies who offer, or banks who offer credit cards with lower rates for like a certain period of time, 6 months or 12 months or so forth and so on. And you can take advantage of that. You can save some money, and hopefully you can pay off that credit card before the time is up. And then before that time is up, you can move to another credit card. And then you can continue doing that as long as you're paying. You don't want to pay only the down payment. You have to pay a lot more than that to really make a difference. That down payment is designed to just pay the interest. So you're not really paying anything out of the principal. Now, the other thing that you need to keep in mind is that when you're buying a car, that is constant. So if you're buying a car today for 6-7%, that stays 6-7% unless you refinance that car, with a different loan. But if you're leasing or something like that, then that stays the same for the remaining 5 years. Normally it's 5 years. If you're buying a home, there are a lot more flexibility there. There are a lot more ways where you can tackle the high interest rate, and in which you can buy points. There are other programs that you can use to lower your points, or you can refinance 6 months or a year from now or 2 years from now when the interest rate goes down. Keep in mind, if you refinance, has to be a winning strategy for you. The market is really, really good. So I encourage you, if you're buying and selling, this is really great time to do both. If you're selling, you're still getting great value for your home. And if you're buying, you don't have as much competition because a lot of people cannot, or some people cannot really get a loan today because of the high interest rate. So this is a good time to talk to sellers and then get accepted. But the market is still hot. You need help, give us a call, 313-819-0101. We'd be more than happy to work with you and help you and let you know what your property is worth. And every case is different. Every individual is different. Every sale or selling or buying is different. So we need to talk to you, see what your situation is, and then tailor a program specifically for you to make sure that you are getting what you're getting. Again, the number is 313-819-0101. Thank you so much. We appreciate you taking the time to be with us. Thank you to Dr. Jafri. Thank you to Meghan Groen for being with us as well. And you have a wonderful, wonderful weekend. And then have a good, beautiful weekend. Bye now.